So yes, over the last few years, we've had some new advancement in technology that has helped us improve our, or at least we are starting to move towards getting an access that probably will help us with our toolbox. Currently, the commonly used accesses are the AV fistula, AV graft, and the tummy catheters. And it's been almost 50 years that we've not moved the needle at all. And now in the last few years, we are at least seeing new challenges, new advances in the right direction. So the HERO device, so the devices that are now currently in the pipeline, some of them have been around for about 4 or 5 years with some clinical data, and the others are really very much in the very early stage. They've just finished their first phase 2 clinical trials, and we hope to see some positive results in the next few years. HERO device that has been discussed extensively in this meeting. We've had multiple sessions where we've shown that the HERO device can be used as a potential alternate access. It's an access that combines both graft and the fistula. So I'm not going to go in discuss HERO device any further. The non-PT graft, bioengineered vessels, very briefly on that. Polytetrafluoroethylene graft. Grafts are not commonly used here, as I've understood, interacting with people. The majority of the patients do have fistula here or a catheter. So non-PTFE graft, I will just briefly mention about it. Bioengineered vessels, the vessel has the bioengineered graft has just completed its first clinical trial, and now hopefully we will see more clinical data. My major focus will be on endovascular tool to create AV fistula, which again is something that everybody is interested in. It's a real novelty, it's real glamorous, and some of my thoughts on how this device will eventually come into play into our management of our patients. And then lastly, I do want to make a point about devices that help preserve central veins. So non-PTFE grafts, so these are early cannulation grafts, so these are electrospun, non-fabric polycarbonate urethane, and these grafts can be used within 24 to 48 hours of placement. They're self-sealing. But again, this is not something I think is relevant in the context here, as the total number of patients who receive grafts in Peru are really very low. Even in the US, the major concern among the surgeons who do place these grafts is the graft material is too stiff, and they find it very difficult to anastomose it to the native vessels. The early data that we have is very similar as far as patency is concerned to PTFE grafts. Bioengineered vessels from allogeneic cells by Humacyte. So this is creating a scaffold on which the cell matrix produces a matrix compound. The scaffold is then decellularized, and that tube now is used to create an arteriovenous fistula. So that tube is now used as a conduit to connect between a vein and an artery. The phase 2 trials have been completed with 60 patients. The results are very promising. 1 year patency is low. It does require multiple interventions like any other PTFE graft. But at the end of the year, with interventions, we can keep the access patent in about 90% of the patients. What I really want to focus on is the 2 new devices, the endovascular AV fistula devices that have been now FDA approved. And I have 2 short videos that will depict how these devices work. Hopefully these videos work. So, yeah, start. So this is a device, the Waving device. This is the first generation device, which was a 6 French. Now the newer 2nd generation device that has come out is the 4 French catheter-based device. Here, 2 cannulas are placed. The idea is to identify 2 vessels in the deeper part of the proximal forearm that are close to each other. The catheter is placed on the venous side as well as on the arterial side. Then using a magnet, the catheters are brought together. Then there is a little electrode that comes in place that is activated, that generates energy, and the anastomosis is then created. So the entire procedure is done endovascularly. The problem here is, as you can see, there are multiple vessels that open up, and that requires interventions. If you can go to the second one. See it? Yeah, close it. So it requires some multiple channels open up, and that then requires either coiling, ligation, so that the blood is then directed into one single channel or two channels that can be then used for using during dialysis. The second device is the ellipsis device, which is a single catheter-based device. They use this with the help of an ultrasound. Again, selecting the patient is very important. So here, the vessels are identified. It's important that the vein and the artery in the proximal forearm are close to each other. The vein is punctured, and through the vein you counterpuncture the artery. The wire is advanced into the artery, and then using a thermal device. So now the cannula is being placed over the wire. The tip of the sheath goes into the artery. And then the device is then introduced through the sheath. The tip of the device is in the artery, the remaining portion is in the vein, and then a thermal activation is created that brings the artery and the vein together and creates an anastomosis. So again, everything is based on endovascular rather than surgical. The problem is still the same. Because these are deeper vessels, first of all, selecting the right patient is equally important. You need to have vessels that are close to each other, no more than 2 millimeters apart, and 2 or 3 millimeters apart. If the vessels are far apart, then obviously the cannula is not going to work, and you're going to create a major hematoma in the forearm. So yes, it has some advantages, but at least in the initial clinical trials, the biggest improvement is there's a low failure rate, few interventions in the early phases, but then the subsequent trials have shown that a fair number of patients do require interventions to get the fistula going. This was just in case if the videos didn't work. I'm going to flip through this. So this is how actually the fistula looks when the fistula is created, and then because of these additional vessels, these have to be either generally not ligated because they're deeper vessels, so one has to go in and block these with coil embolization. On histology, of course, the anastomosis that's created, the fistulous tract that is created is pretty clean and neat. This was done in a sheep model, so it works, but it has its negative points. So the first study based on this device was published in 2017. They had an initial 20 patients where they were trying out the technique, and then they enrolled 60 subsequent, or selected 60 patients, which were then evaluated over a period of 1 year to see how the response was. And as you can see, there were highly selected patients from this side of the table, that you can see that not a good candidate per investigator, 7 candidates were excluded. So what does that mean? We don't know. But clearly, this was a highly selected population. And the patients who did get the access, they had 2 outflow tracks and then multiple sites for cannulation. And as you can see, the cannulation sites were either selected in the cephalic region or the median cubital region, basilic vein, the median cubital basilic vein. So multiple sites could be used for cannulation. 64% of the AV fistulas were functional, and 52% were functional without intervention, which means almost 50% of them required multiple interventions. And as you can see here, roughly every 6 months they needed some kind of an intervention to make the fistula functional, to be usable. The response, the results were pretty similar with the ellipsis trial. This was again a 5-site study, total of 107 patients were enrolled. The technical success rate was 95%. Procedure time was 23 minutes, which I don't care whether it takes 23 minutes or it takes 1 hour, as long as it works. But as you can see, the number of interventions that were required, balloon dilatation of the anastomosis was required in 72%, embolization in 30%, so 1/3 of the patients. Surgical transposition was required in 26%, so we really gained much. And then surgical cubital ligation, vein ligation was required in about 31% of the patients. Number of secondary procedures required were at the anastomosis, embolization, transposition, so and stent placement. So yes, you can create an AV fistula without the surgical scar, but then subsequently you spend a lot of time trying to get the fistula going. When you look at the patency, yes, the cumulative patency at 1 year was fairly good, 90%. Functional patency was pretty good even at the end of 1 year. Complications, yes, ton of complications. Early thrombosis was there, anastomotic stenosis was seen, coil migrations, vein rupture, central stenosis, cephalic arch stenosis. All of the complications that you normally see are seen. In addition, you have a fair number of infections. I would say in a small population of 100, you have still infection, neuropathy, vein rupture, and coil embolization. So these are not simple, straightforward procedures. And very recently, just 2 months ago, this was a retrospective data on 105 patients was published. It showed that the physiologic maturation rate was 98%, and the definition they used was 4 millimeters of vein with 500 milliliters per minute of blood flow. So yes, the fistulas do mature, and they do have a patency at 6, 12, 18, and 24 months. It's fairly high, but it comes with a cost. Cumulative patency at 2 years is still over 90%. So that's really a welcoming outcome. So clearly, the endovascular AV fistula is one more tool in our toolbox, but it has to be used very judiciously. We have to select the patients, and as long as the right kind of patients are selected, maybe there is a road in future. It just doesn't mean that the surgeons are losing their job. One thing that I really want to emphasize on is we do have a device that can work to at least preserve central veins in some of our patients. Our CKD patients and dialysis patients do have a lot of cardiac problems. They do get cardiac rhythm devices or multiple kinds of electronic devices, implantable electronic devices. And these are the conventional ones that have, depending on whether it's single pacer, single chamber, dual chamber, pacer, or pacer with defibrillator. There are multiple leads that go through the subclavian vein and they travel through the transvenous route. Once they travel through the transvenous route, there is enough crowding in the SVC and the brachiocephalic veins that they lead to stenosis. In patients who are not on dialysis or do not have an access, they do not manifest clinically, but they still have a fair number of stenosis that in a select population where they look specifically for stenosis, 64% of the patients did have stenosis, though only 2% were clinically symptomatic. On the other hand, in the dialysis patient, as soon as they get an access on the same ipsilateral side, almost 70% of the patients become symptomatic. And so with patients who already have a cardiac rhythm device in there, one way to avoid is planning and preventing placing an access on the ipsilateral side. That would be an easiest way. Angioplasty, stenting, or access ligation if they do develop symptoms of central venous or thoracic outlet symptoms. But now with the alternate approach that we have, that we can avoid transvenous lead placement, There is a leadless spacer that was approved, and I don't know if anyone has used this here or you are aware of this being used. These are leadless spacers, so there is no lead that traverses through the venous system. And two of these devices were approved. One is a nanostem, the second one is microsystem. Most commonly used in the last few months or a couple of years in the US is the microsystem that is used. So these are small pacers that are smaller than, as you can see, a 5-cent coin. The microsystem is smaller than or as small as a paperclip. So if you can compare it here, that's the conventional pacemaker, which has multiple leads. This is the leadless pacemaker. The current device is a single chamber pacer, so obviously the indications are very limited at this point. But the device that's in the works, in the pipeline, is going to be a dual chamber pacer. So these devices are small. They have battery half-life of anywhere from 8 to 15 years. And the first study got released and published in 2016. The main indication why this device was invented was to prevent pocket infections in patients who had the conventional pacer placed in. But I think from our standpoint, from our patient's perspective, we can save the central veins if we can avoid the leads traversing through the central veins. And here's the device, if you can see it, that was placed in one of my patients who had a catheter. Now, so already there's a catheter. If the patient has 3 extra leads traveling in, there's a lot of crowding in here. So this patient was had the right indication. He got a leadless pacer. So obviously we are hoping to save some of the damage done to leads in the central veins. So looking into the future, it's promising, it's exciting. New options are slowly transitioning. It's time that we advance. It's 50 years since we are stuck on the same 3 access types. The dialysis machine has changed tremendously. We've got so many safety features on the dialysis machine, but our access has still remained essentially unchanged. Early studies are encouraging, though we still need to be very selective in using these new technologies in our patients. Continuing education of dialysis staff is essential. So if the patient gets a fistula through an endovascular technique, the dialysis staff will not be very familiar with it. So they have to be equally trained, and that's a whole new process that has to go side by side. And finally, we still need to focus on improving our process of care, because that's where I think prevention comes in, that's where early recognition comes in, and if we can bring that also side by side along with the new technologies, it really would help our patients. So thank you very much for your attention on this.